So it's my great pleasure now to invite my good friend, Dr. Rohit Shetty. He's going to be talking about a very important topic, dry eye disease and ocular pain. Thanks, Rohit.
So in between multiple beautiful technologies and videos, I just want to bring in the concept of dry eye, which many times is completely ignored. But one unhappy patient with ocular pain can mess around with the entire practice. These are my research with whom I work. I know nothing directly linked to these presentations. So if you look at basic pathophysiology of pain, it starts with injury, how the nerves respond to it, release of neuropeptides, and what it does once it releases, how it works on your inflammatory mediators. And this is how it works. And anything which you work on balancing it is something which can reduce your pain aspects. One major challenges which we see both in our clinics as well as in post-refractive surgery is pain without stain, where you have all your parameters in normal, but they're just not happy. They just keep coming to you being unhappy. And there is an aspect of neuropathic pain, and there are a lot of related stuff on this: systemic disorders, ocular surface injuries, medications, including neurological and psychological problems. So one is about having a lot of extra nociceptive effect. That means you are more sensitive, and these have two neurons. We can subnormal and abnormal inputs, which can be allodyna. You do have a lot of questionnaires on this. And symptomology, most of them do suffer from more than 3 to 6 months, and there are different methods to evaluate, from stissiometry to topical anesthetic test, to see difference between the central versus the local causes of ocular pain, and of course the role of confocal microscopy. One of the most important thing in confocal microscopy is ability to pick up neuropathic pain versus an ocular inflammatory driven pain. These cells, for many years, we were looking at it as dendritic cells, but now we have to look at the re-terminologies. These are T cells. They don't have those dendrites. They are those white dots here, and mature dendritic cells. And you can have a mix of dendritic cells, and some of them lying very close to ocular subbasal nerves. What we have published is, if they're closer to the nerves, the pain is more. And this is something which happens by chance or by nature. You got nothing to do with it. There are so many of them who may be away from the corneal nerves, and they will just not have those pain factors there. And there's a huge component of microneuromas which we don't pick up. And these microneuromas can be a major factors from ocular pain. So can we have a classification system? This is me and my colleagues did publish this paper, which is a discordance scale, where it's difference between the symptoms versus the signs, and how the discordance between them. And if you look at the confocal microscopy, again I've shown you the picture. The microneumas again shows chronic pains. Dendritic cells are changing, dynamic. So if you treat them with steroids or keep them on immunomodulator, probably they might actually reduce. If you look at the molecular aspect of it, we studied with in the initial part of the paper, where we used the CBA analysis to look at all the molecular factors. And you can clearly see that there's specific molecular pathways involved in pain, and this is driven by the interleukin 17A. Why is it important? Is because when you know that there are specific markers which are linked to pain, you can look at markers which can actually reduce it. And this is something which is very chronic: post-cataract surgeries, post-refractive, post-vitreoretinal, many things. And one of the reasons we had to look at the role of vitamin D in this neuropathic pain is what we published here. The patient's vitamin D has a huge impact in maintaining the nociception. It controls the nociception. When you have a low vitamin D, the nociceptive factors increase. So that is one of the reasons is all the factors here which are necessary for nociception increase. That means the person who becomes 100 times more sensitive than somebody who has a near normal vitamin D. And this is also driven by vitamin D receptors in your cornea. So there's no uniform algorithm to manage this pain. So what we looked at, say, if looking at this particular case, in the interest of time, I'll run fast with patient non-resolving pain, and you can see that his T-but is low, but no staining, but you can watch the eyes on a very high level. His all the other parameters looks completely healthy. But what we started looking at with our the point of care kit is where we have a stall in AIOS this time where you can analyze your tears and you understand what it does. Is these patients had a very high level of certain markers, and one of the markers which I did mention in the past was IL-17, which is not always controlled with your steroids or your cyclosporins or your tractonimus. So what we did was, in this patient, and this again we published, microneuromas have a very high level of, somehow they are linked with the IL-17 response. So what we did was, in the past we had published this work where we used the intrinsic pulse light or IPL therapies. This was an highlight at that point of time. And what we found was one of the factors which was very well controlled with this was IL-17. So this is how you look at how you can use it and titrate it. And even MMP9 can be controlled by your lipid flow. So when you combine both, it works as a very good combination, and you can see that both your markers suddenly drops down, and this is just with one sitting, and pain also starts reducing. So there's no specific marker which can block the MMP with the IL-17. The cyclosporin does work on IL-2, IL-6 and MMP9, but that's why you have to combine sometimes therapies, and when you need combine, because the lipid flow works extremely well when you have a high level of MMPs or IL-6, and IL-17 works well with IPL, and when you combine both, this is what we get. And this is again a patient who was advised LASIK, but when you see closely, there are microneuromas, and if you do a LASIK and you damage those nerves, it's chronic neuropathic pain again for life. So what we did was, and this is a confocal microscopy of it, what we did was we went deeper. We went 150 microns in this patient. We can use the SMILE to change your cap depth, and you can see that the microneuroma still exists without disturbing it, without much changes on her ocular surface or her pain status. So this is just a brief flow chart of what we look for if you have access to it. Ocular surface inflammation is a major one. It correlates with OSDI. Microneuroma has a huge impact in your neuropathic pain, and binocular single vision. When you have a very, very bad stereopsis, you complain of pain which mimics a neuropathic pain, but it could be related to his stereopsis. And it's very important to always look for his stereopsis before you label anybody on this. And this is just a flow chart which talks about anti-inflammatory therapies of cyclosporin and dysregulated. We have to really, there are so many areas where it's need for future therapies, where you need to look for targeted therapies. And when you know that it's a neuropathic pain without any ocular surface issue, there are role of autologous serum, tricyclic antidepressants. So the pain without stain is quite common in refractive surgery. The commonest one is binocular issues, not the corneal issues. And the role of molecular assay and future therapeutics will probably help in managing this much better. Thank you.
Well, I'll just ask a quick question. It's excellent talk and on a really important topic. Can I just ask two questions? One is, from your experience, what is your estimate percentage of neuropathic pain in refractive surgical patients? And the second thing I was going to ask was, one of the advantages of your point-of-care kit is really the fact that very few people have confocal. And I think that that's a game changer for a lot of people if you can, more people can get that point-of-care testing kit to use, because you know there's issues with the HRT machine itself, and I think that would be a big game changer for a lot of people.
The classic neuropathic pain, the percentage is very less, maybe 0.1% or less. But patient comes with pain. Most of our pain patients all have binocular issues. Because when they feel stress, when they start working, eyes start hurting, it's labeled as neuropathic pain because they don't find anything else in it. So that's the first thing. The classic neuropathic pain is very less, but whenever we see ocular pain, or if you just do the confocal of them, most of them end up having some microneuromas, or a lot of those T cells. But T cells, when you have, you know what to do, you can treat them. But because the pathways of pain is driven, 3 papers we published is classically driven by the IL-17A pathway, which changes the ocular epithelial cells. We feel that combining it with any of your IPL, for some reason it works well, or all IPL works well, plus the LipiFlow reduces pain in a lot of them because it balances both the factors.
Yeah.
The point of care kit is now becoming a reality. There's a stall there where you can pick up and you know which part of the immunology you're dealing with.
How long will the LipiFlow work for? Because of course it's just a one session treatment, right? So what's your duration of action? So there'll be a window period in which you have to do your refractive procedure.
LipiFlow, if you do a LipiFlow and take the patient next day, the eye is filled with inflammatory thing. So we wait for a week.
A week. Okay, great. All right, thank you.